Hi everyone, my name is Dr. Lasker. I'm a consultant radiologist. I'm doing this live stream on Facebook for the first time ever. I'm doing this on behalf of radiology seminars, and I'm hoping that everyone gets to learn a few things, and I'm really grateful for those of you that have turned up. We're just going to give a minute or so just for people to turn up and just log in. If you can hear everything, just let me know. Give me a few yeses and heys, and just let us maybe know where you are in the world. That'd be really interesting to know as well. So what we're going to be going through, hopefully, is going to be a bit of just basic anatomy on this particular lecture, just so that we kind of get acquainted with anatomy of the abdomen and pelvis. And also, this will hopefully set us up for the next few lectures that we've got planned. Just waiting a few more seconds just to make sure that things are running okay. Sorry about this, everyone. Just want to make sure that things are going okay. So I think I'm getting the go-ahead to carry on. It's all very exciting. Fine, so like I said, my name is Dr. Lasker. I'm a consultant radiologist, and I'm going to be going through some very basic anatomy when you're looking at a CT scan and how to approach a CT scan when you have this in your normal practice. So first of all, let's start from the beginning. This is a CT scan, okay? And do we know whether it's got contrast or not? That's going to be one of the big questions that we're going to be asking ourselves. So the way I normally do is actually when you come down to the kidneys, maybe it's a bit rudimentary for some, but when you look at the kidneys, you can actually see some of the detail with regards to the cortices and the rest, with regards to the cortices, and also that you can see that the aorta is slightly more dense than it otherwise would. When you've got a non-contrast scan, that wouldn't be the case. You'd have the same density with the liver, you'd have the same density with the kidneys, the aorta, the IVC, the aorta, all the vessels, all the bowel would be exactly the same density. Whereas here you can see that there is a difference with regards to the brightness that the scan is looking at, when you're looking at the different organs. And so now you understand, okay, this has got contrast in it. What phase is it? That's the next question. And the way I usually do it is try and identify the aorta. Which one is the aorta on this particular scan? So hopefully some of you may be well versed in CT scans, so it may not be that difficult. But the aorta is on the left. Okay, it's always on the left. Well, yeah, it's always on the left. And in radiology world, this over here is the left, and over here is the right. And so on the left will be the aorta. And I try and remember that using this really silly phrase, AOL. So I don't know if any of you guys are old enough, maybe just giving away my age, but for a while, AOL was the go-to web server. The internet provider. Honestly, everyone had an AOL address. Maybe some of you will be able to tell me whether you even remember AOL. I think it was like American Online. And I just remember that phrase. It sounds so silly, but I remember when I was beginning radiology, I used to even have difficulty knowing which of the two vessels was the aorta. And thankfully, that's not too much of an issue now. It's almost second nature. But I think some of what I'm trying to do here is try and cater for all levels. So AOL, American Online, is a good way to try and remember which one of these two vessels is going to be the aorta. And so AOL means that aorta on the left. It's really silly, I know. So, some of you might be scoffing at me like, why on earth would anyone use that phrase? It's something I used to use. Thankfully, I don't need to use that so much anymore. So the aorta is on the left. So this is the aorta. This is your IVC. So now you know that this is venous and this is aortic. You want to see which of these is brighter. And yes, the aorta is brighter, but if this was an arterial phase, this would be a really bright vessel, almost as bright. It would look almost as bright as the bone here on this particular window. So because they're almost very similar in terms of their density, you'd be saying to yourself that this is not arterial phase of the scan. So then you'd go to the portovenous phase. You can see that it's slightly more dense in the portal vein. So this is the portal vein that's going into the liver. And because it's slightly more dense than the aorta, you'd be pretty safe to say that this is a portovenous phase. And the portovenous phase is the phase that is very useful when you're looking at CT scans. It's actually almost a go-to phase when we're doing acute studies. I think it's about 70 seconds. So you inject the contrast, you wait about 70 seconds, and then you take that scan, and that should be sort of delayed portovenous phase of the image. Sometimes you want to go even more delayed than that. You may leave it for 10 minutes, and in that situation you'd be going for a very delayed scan where it's all been filtered out by the kidneys and it's gone through into the ureters as well. So that's kind of a really basic way to know what kind of scan you're looking at from the outset. My recommendation is that whenever you're looking at a CT scan, you don't just look at, the first bit and you kind of stop there and you're thinking just, oh, what's that? Is that the liver or not? My recommendation from the very, very beginning when you're starting to look at scans is to go from the top and all the way down to the bottom. So let's just do that now. So this is what I mean. You start from the top all the way down to the bottom. It doesn't matter whether you pick anything up, you're seeing anything abnormal or any of those things. Just go for it. Just go for it all the way to the bottom, right? So we've gone to the very bottom of the scan, and sometimes that's a really good thing to do, just so you kind of get a flavor of what's going on the scan. And as you get better and better, things that are abnormal will really just pop at you. They just jump at you like, oh, that's something that's not quite normal. The other point, and this is a really important point, that sometimes people get really fixated on something. Let's say, for example, there was a lesion sitting right here. And you get so fixated on that lesion, you're thinking, oh, is that hemangioma? Is that a cyst? What, and you start, Googling away, oh, is this a cyst? Is this a hemangioma? What could this be, right? But in the meantime, they could have a raging obstruction, like a really bad obstruction, and you're faffing about looking at, what liver lesions are and what imaging to use to try and find out what particular kind of lesion this could be. Or, for example, even worse than that, they could be like bleeding, that kind of big intra-abdominal bleed, and they're really in a bad shape, and you've kind of got stuck right at the top, still looking at this particular lesion. So my first big piece of advice is, look, when you got a scan, go all the way from the top to the bottom. So from top all the way to the bottom. So I'm going to go down this, and maybe some of you might be able to see the abdominality. Yeah, I know I'm really meant to be giving you a normal scan with nothing on it, but I couldn't help myself. I had to keep you guys on your toes, try and get you guys to try and stay awake, for those of you that are already quite versed in CT. Right, so once you've done that, let's go from the very top and go through the anatomy. So I'm going to go through very basic anatomy. There's all sorts of more intricacies with regards to this, but this is the liver. Okay, and this is split into 8 segments, and in the beginning when I was doing reporting, I just used to look it up. Every single time I'd look it up. Over the years, I think I used to use segment 6 as like my go-to. Segment 6, which is going to be this bit here, so the inferior tip of the liver is segment 6, all right? And then the other segments that you should be aware of is segment 4, which is kind of in the region of the gallbladder, around here. And 4B is going to be sort of below, sort of just, kind of inferior part of sort of where the gallbladder is touching the liver, and anything above that is going to be 4A. Okay, so that's really, really rudimentary way of looking at things. And then anything on this sort of triangular region here is going to be segment 2 or 3. 2, for, just for the sake of being complete, is going to be here. 3 is going to be sitting in front over there. So now you've got segment 2, 3, you've got 4, and then that 6 is going to be down here. So whatever's between 4 and 6 is going to be 5, okay? And when you come to the very top of the liver, your dome of the liver, you're going to be looking at sort of segment 7 and 8, okay? It does take a bit of a while, but maybe just use my landmarks, okay? 2, 3 is going to be the sort of triangular area here. 4 is going to be in the region of the gallbladder, down, inferior is going to be 4B, superior is going to be 4A. Segment 6 is going to be that inferior tip over here. And once you've got that, you can kind of, figure out the rest. Where's number 5? Where is number 7? Where is number 8? So a bit rudimentary, I know, I'm sorry, but I think that is a quick way to try and figure out where you are. And if you really want to be very, very accurate, go on the internet, look for the diagram, and you'll find it. Okay, so next thing we've got the gallbladder. Okay, very important to look at the gallbladder. A lot of pathology can happen there. No doubt most of you be aware that if someone has got gallstones, they could have inflammation in that gallbladder. That gallbladder can perforate. There's all sorts of things that can happen when you've got inflammation in that gallbladder or some pathology with regards to gallbladder. Important note is that often gallstones aren't radiopaque. What I mean by radiopaque is that a CT scan is actually a glorified X-ray. And so when you've got a glorified X-ray, it's not everything is dense enough to stop the X-rays from going through. And so sometimes stones aren't very dense, and so they don't result in sort of obstruction of the radiation that's going through the patient, and you might not see stones at all. So when you're reporting, you can say something like, there are no radiopaque calculi in the gallbladder, but there may be calculi, there may be stones, but you can't see them on CT. Sometimes you have very cholesterol-rich stones. Cholesterol-rich stones are ones that are full of fat. So when they're full of fat, they will look almost the same as the fat. So the fat here is a subcutaneous fat here. You've got intra-abdominal fat. And so you may have the situation where you've got a bit of, low density stuff sitting inside the gallbladder. And those are going to be cholesterol stones. Okay, so we've done the liver, we've done the gallbladder. Let's carry on with the biliary tree. So when I do my reporting, I try and report in terms of systems. So I would say something like the liver looks normal, no lesions, gallbladder does not show any evidence of any calculi, the intrahepatic ducts also look normal. Right, so that's another thing we need to be looking at, the ducts. So the ducts, the intrahepatic ducts, sit right next to the blood vessels, these hepatic veins and the rest of it. And so if you can't see them, that's a good thing. If you can see them, that's a concerning thing. But sometimes you may have someone who has got a lot of edema inside their body. And in that situation, you may have someone who's got sort of low density lines on both sides of the vessel. If you've got low density lines on both sides of the vessels in the liver, you're not looking at intrahepatic duct dilatation. You are in fact looking at portal biliary, you're looking at portal edema. Whereas if you've got a low density line on one side of the vessel, that's when you're thinking about intrahepatic duct dilatation. So that's another little clue, another little tip to be aware of. And don't worry, as we go through the series, I'll find some good examples for everyone to really get their teeth into. So we're carrying on with the sort of biliary tree style of things. We can look at the head of the pancreas, which is going to be over here. And then it kind of this fluffy, feathery like thing that kind of goes along that way, goes along that way, and goes along that way. Generally speaking, the pancreas should sort of taper. As time goes on, as people get older, it can become quite atrophied. So this is kind of quite a healthy looking pancreas, but you can have fat stranding in that region. You can have all sorts of inflammation and that kind of thing, which should be basically pancreatitis. Important piece of anatomy when you're looking at pancreatitis is that you've got this vessel here. You can see that vessel. Can anyone tell me what that vessel is? I'll give you a few seconds. Can anyone tell me? That vessel, I'm just going to point it out again, going behind the pancreas, there. So not very well drawn, sorry. But I mean, hopefully you guys can see what I'm trying to point at. So what can happen is that you can have inflammation of the pancreas, which results in sort of inflammation of, that sort of inflammation around the pancreas can start to cause inflammation of any of the surrounding structures. And that can actually result in thrombosis of this particular vessel over here. And some of you may have got it. That thrombosis of that vessel would be a splenic vein thrombosis. Yeah. One of the other complications is that yes, you do have a splenic artery, and over time, when you've got sort of chronic inflammation or someone who has a few bouts of inflammation, you can actually end up having aneurysmal appearance to a part of the splenic artery. So, I mean, that's just some really good anatomy and just how it relates to some pathology as we're going through it. Right, so we've done sort of the liver, we've done the gallbladder, we've done the intrahepatic ducts, and we've gone on a bit about the pancreas. Next thing would be to look at the adrenals. The adrenal glands are these tiny little V-shaped things that are sitting here and sitting here. They sit right on top of the kidneys, and they should be very, very thin. So you may have a bulbous appearance, it might look a bit thickened, and in those situations you end up getting a dedicated CT adrenal glands. You don't always need to do, no, you should always do one, but what I'm trying to say is that generally speaking, they don't usually end up being, pathological. I think they call them incidentalomas. And maybe some of you guys might be aware of that phrase. But anyway, sometimes you could have a nodule there that which may need to be investigated. If it's a low density lesion, i.e. the same density as fat, which is sitting over here, then you can be pretty sure it's a very sort of fat-rich density and therefore nothing to worry about. Below those adrenals, you've got these structures here, sitting here. Okay, and I did allude to, I have mentioned them earlier. For those of you maybe coming a little bit late, no worries, you can hopefully watch the recording afterwards. These are the kidneys, and you've got, the medulla, and you've got your calyces sitting here as well. And if you've got obstruction of this will look very, very blown up. Okay, these areas will look like Mickey Mouse gloves. Okay, and they will literally look like, like this, like a Mickey Mouse hand. And that would be indicative of obstruction. Be careful though, because sometimes people can have parapelvic cysts, and they will actually be more spherical. They won't sort of join with each other, and that can confuse a lot of people. And I've seen patients who have multiple scans trying to figure out why they've got hydronephrosis, and they've just got parapelvic cysts, and they've always had it. So in that situation, previous imaging may be useful, ultrasounds can be useful, and yes, sometimes you might need to do a different kind of scan to be able to try and figure out what is going on with that patient. Now, when you're looking at the kidneys, it's really important to look at the kidneys really, really well, because sometimes when you do have an RCC, a renal cell carcinoma, they can be very similar in density to the actual kidney themselves. And so that's when it's really useful to look at multiplanar images. And I'm just going to do a plane change now. And I find that coronals are very useful, and so are sagittal images, just to make sure that these don't have like an abnormal bump. Because on some orientations, it can be a bit difficult to actually appreciate any abnormal bumps on the kidneys, and any abnormal bumps that are of the similar or same density, you probably should be investigating a bit more. Okay, so that's very important as well. So we've done the adrenals, we've done the kidneys, and just to stick to the same principle of going through systems, we're going to have a look at the urinary bladder. Urinary bladder, generally speaking, is not very well assessed on a CT scan. Not very well assessed at all. But it's very good to try and have a look at it anyway, just in case. I've had situations where the catheter balloon is nowhere near the urinary bladder, and they're very distended urinary bladder. On the occasion, you may see a mass. Usually, in older patients, you might have a bit of a diverticulum, sticking out on either side. But generally speaking, like in this particular example, the urinary bladder is not very well filled. So I would be hesitant to say there's anything abnormal. If you're really concerned and you think, oh, it is a bit thick-walled, you could say, look, the urinary bladder is not very, it's thick-walled, but it's not adequately distended. May need further investigation with a dedicated ultrasound study. So ultrasound is usually a good way to go when you are looking at the urinary bladder. And then one of the other upper abdominal solid visceral organs is going to be the spleen. So the spleen sits over here. Okay, so I've seen a few different ways to measure it. When you're trying to measure whether it's big or small, you can measure it sort of in a bipolar length like this. Badly drawn, sorry. And then you could also measure it like this as well. So coronal images go from top like this, and you just draw the line like that, and then draw that measurement there. That's another way to measure it. It's quite important to try and make sure that you measure that correctly, because I've seen a few times that people have said that the patient's got splenomegaly, and actually when you look at it in multiple planes, it's okay. And then this is a good example here actually. You've got a bit of a spherical density that's sitting there right next to the spleen. Some of you may, some of you may know what that is, some of you may not. Let's see, can anyone guess what that is? That's sitting right there. So I'm going to describe it. So it's a spherical density. It's very, very close to the spleen. It's actually got the same density as the spleen. So that's a bit of a clue. And actually, when you look at the pancreas that's nearby, it's not quite the same sort of fluffy appearance. It's very, very spherical. And, in truth, it looks almost identical to the spleen. I suppose for argument's sake, you could say it looks a bit like the same density as the kidney. So some of you may have got it, and, good, great. So we can see that is a splununculus. Right, excellent. So this is splununculus, and it can be a very, very normal thing to have. It's usually found in this particular region, and there's nothing to worry about. What can actually happen is that if someone has a shattered spleen or they've had a splenectomy, bits of spleen can be left behind, and you can end up having these sort of very weird sort of spherical lesions, in a few places. And that can be bits of remnant spleen that have actually grown over time, and I've seen that a few times. So, if you've got a few circle areas and you don't have a spleen, then you're thinking about remnant, splenic rests, I think they're called. So yeah, good, excellent. So bowel can be really difficult. I think let's just start from the top. You want to see whether they've got any hernia, so that's the esophagus coming down here, and you want to see whether they've got any sort of outpouching of the stomach, and you want to have a look at the stomach as well. And as you come down, you'll have your pylorus, and you've got your first part of the duodenum. So if you've got someone who's got a perforated duodenum, usually you'd have a lot of air in the upper abdomen. So what density is air? It's going to be this density here. All the stuff that's sitting outside the body is air. So you may have that sort of low density stuff sitting inside the abdomen. And if it's very predominantly within the upper abdomen, I would almost say 9 times out of 10 is going to be a perforated duodenal ulcer. Something along those lines. To the point that if you've got a lot of air sitting in the upper abdomen, you haven't seen anything else, you could literally say, in the absence of any other findings, there's a predominance of intra-abdominal free air, predominantly in the upper abdomen. This would most likely be consistent with a perforated duodenal ulcer, although I have not been able to identify that on the CT scan. It can happen. Right. And then, once you've done that, I actually just generally go from the top, I actually go from the bottom, quite literally actually, from the bottom. You come all the way up, so you've got your rectum here, and you just want to follow around. And this can take a bit of, radiological ninja skills, up and scrolling up and down, trying to see where it connects. And, when you can't see it connecting, just scroll up and down and see, oh, yeah, it does connect, all the way like that. And you want to see what the bowel is looking like. Yeah, and you look, I'm still here, and it's going upwards. Yeah, going upwards. And you look, I'm going to keep that mouse there. I want you to keep your eyes there. And this is how to track, I think they call it tracking the bowel, following the bowel. You want to go up, and look, my arrow doesn't have any bowel in it anymore. So you want to come up and down. Oh, okay, there's still a bit of bowel. Where does it go? Oh, it's going this way. It's going this way. So now we're at the splenic flexure. Spleen, flexure, splenic flexure. Okay, we're over here, coming across. Look, and and go up and down just to see where it goes. Up and down. Look, there it goes. This way. Look, it's easier. Honestly, I remember when I was a reg, I used to watch my consultants do this, and it looked really easy. I was like, yeah, I'm going to do it too. And actually, when you're doing it yourself, and for the first few times, it's actually really difficult and can take a while. And look, you want to follow this. Oh, where does that go? My arrow's still following it. Where does it connect to? Oh, look, bend down this way, and look, we're at the hepatic flexure, the liver hepatic flexure. And then we're coming down, all the way down to the bottom. And then you've got your ileocecal valve. Now, I'm going to zoom in on this bit here because I think it is... I'm going to zoom in on this bit here because I think it's a very useful skill to have. So, the ileocecal valve has got a bit of fat around it, this valve-like thing here. Fat, what colour is fat? It's the same colour as this over here. Well, similar. But you'll see almost like a lip-like structure, like lips, like there's some lips, low-density lips there. So that's going to be ileocecal valve. So a good way to identify where you are on the scan and in the bowel. So you're at the ileocecal valve. So anything coming out of that area is going to be sort of your terminal ileum and going all the way like that. So actually, generally speaking, I don't really follow the small bowel all the way, because it is quite convoluted. It's a really, really long way, especially if everything looks normal. So then once I've done the following around of the large bowel, I keep my eyes in the center of the screen. I go from the bottom and I come all the way up, and I keep my eyes on the center of the screen, coming up, just to make sure that there is no evidence of any gross abnormalities when it comes to the small bowel. Right, so we've done the small bowel and everything looks okay from that point of view. So the final bits of this scan to be looking at are going to be the lung bases. Now you wouldn't believe, especially in this day and age with the coronavirus thing, very, very important to have a look at the lung bases. You switch to lung windows, so look, we're at soft tissue windows. Lung windows are going to be these ones because now you can see the lung parenchyma really, really nicely. And you just want to make sure that there's nothing abnormal, there's no nodules and all the rest of it. And that's going to be a separate series of lectures in itself, looking at the lungs. Once you've done that, you then want to be looking at the bones for completion, for completion's sake. Sorry, once I find the bone. So this is the bones. Now you can see the trabeculation quite well. And you just want to make sure there's no evidence of any lesions or any fractures or any pars defects or anything like that. I'm kind of going through it quickly because we don't have much longer, and I do want to get through to the answer before we finish this live session. I hope everyone's having a good time with this live session. I hope it's coming across clearly and we're all learning something. But anyway, I went to sagittal views, and just take my word for it, there's nothing wrong with the sagittal views and of the bones. So I'm going to, I don't know, has anyone seen it? So I'm going to come down to this slice over here. Let's see if I can get it. There you go. So this slice here, this is where the pathology is at, and this is where I'll tell you what the symptoms were. It was left iliac fossa pain, and they were thinking it could be diverticulitis. So I will give you guys 30 seconds starting now to try and figure out what this is. So I'm going to keep it here. Hopefully people are, come on, let me see some answers. Let's see some answers. Keep going, keep going, keep going. Anyone seen it? Okay, look, first of all I'm going to say it's not diverticulitis, all right? It's not diverticulitis. I think that would have been a bit too easy, all right? Okay, so I think we are, I've lost count. I think we've reached about 30-ish seconds. Right, so diverticulitis, some of you may have thought it's diverticulitis. Okay, there's not very much in the way of diverticular disease. Okay, so diverticular disease will be these sort of outpouchings, I'll try and draw, this person doesn't have any, but I'll try and draw some diverticular. There'll be these sort of outpouchings like so, so it's not diverticular. It's not diverticulitis, there's not very much diverticulosis, but actually look, if you look around this area here, can you see the fat looks a bit stringy or strandy? Fat stranding is what we call it. And actually look, if you look at the fat there, compared to the fat here, compared to the fat here, it doesn't quite look the same colour, or it doesn't look the same density. That fat in this region here, can you see that? Compared to the fat in this region here, is very, very different. It looks a bit more dense. And so that is inflammation, okay? And that is actually inflammation of the appendage. So this is called epiploic appendigitis, not appendicitis, epiploic appendigitis. So you get these finger-like projections that are helping, keep everything in place. And what can happen sometimes is that that epiploic appendigitis, the appendage, can actually infarct. And that's what can happen. You can have this, so this is the mesenteric side, this is the anti-mesenteric side on the other side of the mesentery, and you can get anti-mesenteric inflammation of an appendage. And that's essentially what this is. Patients can turn up with a lot of pain, very, very convincing of, something quite serious, and actually they've got this infarcted appendage. So how do you treat it? You don't treat it. It's conservative management. So the last thing you want to do is take this patient to theatre saying they've got appendicitis, when they don't saying that they've got diverticulitis, when they don't actually have any diverticular disease in the first place. And when you've got left iliac fossa pain in a patient, you want to be looking in that region anyway. You want to see if they've got diverticulitis. You want to see if they've got any hernias, see whether there's any sort of bowel poking through that's been causing any of the issues. And then you want to be thinking along the lines of, okay, if I don't have inflammation, if I don't have diverticulitis, I don't have a hernia, but this patient's got left iliac fossa pain, one of the things I want to be thinking about is epiploic appendigitis. Epiploic appendigitis. That's a very important finding. So anyway, I couldn't help myself. I wanted to give you something to go away with, not just basic anatomy, but we've gone through, contrast, what kind of scan it is abdo-pelvis, contrast, whether it's contrast or not, what phase of the scan is, this is a portovenous phase. When you look at that, the portal vein is a lot brighter than the other vessels that are around. Portovenous phase. And we've gone through some of the anatomy. I know I kind of went through the liver anatomy a bit quickly, but hopefully you've taken away how to find segment 2, 3, 4, 6, and then from those few segments, figure out the rest of the segments. And we've been through the biliary anatomy, the renal anatomy, the splenic, the spleen and the urinary bladder, and some of the things you want to be looking for when you're looking at the bowel. Right, I hope that's gone okay. I hope everyone's been able to watch it. There's been no slowdowns, and the connection, the volume has been good. And this is, one of the first live kind of things that I've done on a social media platform, and I really genuinely hope that it's been useful. And we've been able to give you a few tips here and there, and I really hope that you can keep up with us. And we're going to be doing sort of regular videos, trying to share the knowledge and get everyone to be, able to help patients, and hopefully from, some of the expertise that we're being able to show on platforms such as this, you can go forward and really help people and help your patients, and we can all learn from each other as well. So if there is something that you've seen or you don't agree with, or you've got any questions, then just hit me up in the comments, find me on my page. I'm also on Instagram and Twitter, and there's a Rad Seminars, social media channels as well that you can contact us through. So I hope that's been useful, and I hope that's been a good one, and hopefully there'll be plenty more of these to go. So give us feedback. Do you like these things? Are these useful for you? And are there any particular subjects you want us to go through? And if so, let's do it. I've myself and Dr. Saeed, we really enjoy teaching. It's a real passion for us, and I think this has been a really amazing platform for us to be able to share some of our passion. Anyway, everyone, hopefully have a good evening, and we'll see you in the next video.